Greetings to everyone with us for today's webinar on laboratory strengthening for COVID-19 and beyond. I'm James White with the LHSS Project, and I'll be moderating today's discussion with our three expert panelists. When the novel coronavirus emerged early last year, USAID asked the Local Health System Sustainability Project to support several governments with their emergency response to the pandemic. Thus far, we've done so in 9 project countries, and importantly, we've sought interventions that not only support the emergency response to this pandemic, but also seek to strengthen a nation's resilience to future health shocks. From the outset, being able to detect and report the new virus SARS-NCoV-2 was critical, and today you'll hear about diagnostic and laboratory strengthening work for the COVID response in several geographic areas. First, my colleague Gulnora will discuss the rapid scale-up of PCR capacities in Tajikistan, with special attention to the planning and coordination that we engaged with other partners. You'll then hear from our colleague Diego from LHSS Colombia, who will discuss the importance of rapid response, including specimen collection at the community level. Our third speaker is Sampawan from our LHSS partners at the Louis Pasteur Institute, who will speak about their experience in Laos seeking to implement rapid diagnostic border screening, as well as their work to genetically sequence the virus. Each of these presentations will highlight how we had incredible successes, but also challenges in the areas of lab strengthening during the first year of this pandemic. I'll now turn over to my colleague Gulnora to discuss our experience in Central Asia and Tajikistan. Thank you, Gulnora.
Thank you, James. For an overall picture, dear colleagues, I would like to dive you into LHSS excellent work done during a limited period of time in Central Asia and in Tajikistan in particular. Next slide, please. Since last April, LHSS COVID-19 emergency response is addressing immediate epidemic prevention, detection, and response needs, at the same time building on the existing in-country national health system and health system resilience strategies in 5 countries in the Central Asia, as shown in the map: Kazakhstan, Kyrgyz Republic, Tajikistan, Turkmenistan, and Uzbekistan. LHSS interventions are aligned with emerging global best practices and USAID Central Asia priorities. LHSS mobilizing the capacities of national stakeholders and leveraging existing platforms to rapidly implement nationally approved plans for responding to the COVID-19 outbreak. Effectively collaborates with all partners projects in the region, such as Eliminating TB in Central Asia, WHO, International Federation of Red Cross, and many others. Next slide, please. This slide outlines LHSS Tajikistan's specific COVID response. Tajikistan is a mountainous, landlocked country with population over 9 million. And by the time WHO declared the COVID-19 outbreak on January 30th and a global pandemic on March 11th, Tajikistan remained one of 9 countries in the world, a country COVID-19-free country, despite high levels of mortality and morbidity described as atypical viral infection and pneumonia until the end of April. In March, Ministry of Health of Tajikistan approved COVID-19 country preparedness and response plan, and LHSS actively ensured development and implementation of action plan for COVID-19 laboratory pillar in Tajikistan, and was first among partners for immediate support to be provided for scaling up national capacities at the public health laboratories, improving and strengthening their capacity. Next slide, please. COVID-19 revealed significant problems in all health sector in general and in laboratory sector in particular. Using collaborative approach and having several quick meetings with Ministry of Health international partners, realizing that no one really is planning to work in laboratory strengthening direction, LHSS decided to take that pillar of rapid response. At central level was no inventory of really working PCR machine in country and lack of laboratory data management, weak of biosafety and biosecurity measures at regional and district levels. At April, needless to say that only one laboratory in the whole country was meeting international standards. No protocol for sampling, storage, transportation of specimens were in place. Lack of government support for laboratory specialists and healthcare workers in general also doesn't help to support trained staff to keep within the system, especially due to high rates of morbidity and mortality. Would like to mention here that, for example, 93% of pilot laboratory staff supported by LHSS has been detected with COVID-19, and unfortunately we faced 2 losses from COVID-related pneumonia among laboratory staff. On top of all infrastructural, political, logistical, and financial challenges, as Tajikistan never introduced quarantine, all population was moving around the country, being possible spreaders. At the same time, necessity of in-person visits for mentoring, monitoring, and supportive supervision put LHSS staff and national laboratory consultants under significant risk. Next slide, please. But also would like to tell you about successes. For LHSS to go for laboratory strengthening was very much a tactical decision. We wanted to attract attention to problem with laboratories. LHSS Tajikistan partnered with Ministry of Health to build capacity of laboratory specialists nationwide and more intensive at pilot laboratory at regional level. Although it was challenging to improve quality control in the context of an emergency response with laboratories operating 24/7, LHSS strengthened laboratory staff capacity on key standard operating procedures and drew support from other partners to contribute to laboratory pillar. By the time LHSS started its pilot work, region had 0 testing capacity, and currently nowadays its capacity is more than 600 a day. Next slide, please. So here is our lessons learned. Timely, fast, high-quality laboratory detection and diagnosis helps to identify, cure, and break the chain of transmission of any infection, not only COVID-19, but in future, which in turn leads to a decrease in mortality. If country has in place emergency response plan, including all health sectors, service provision, laboratory, prophylaxis, supply chain, that can be adapted to concrete scenario, this country will be efficient in case of any outbreak, not only COVID-19. Emergency action can align with resilience and strengthening of health sector as experienced by LHSS using HIV and TB sectors of care in prompt response. Strengthen training for IPC, specimen collection, handling, use PPEs, and case management of possible future outbreaks. It is very important to build and keep good working relations. Having strong reputation of respected and truthful implementing partner, we build solid relation with government, especially with Ministry of Health, that made possible immediate action from LHSS to support emergency response. Next slide, please. And at the end, I would like to share the success of LHSS. In August 2020, 3 national laboratory trainers from MOH supporting LHSS training received a medal from the President recognizing their exceptional service in country COVID-19 response. Thank you very much for attention.
Thank you so much, Gulnora, and I think your presentation has really highlighted the importance of both detecting but also acknowledging cases in the early phases of an epidemic, and how the coordination of multiple partners can emphasize strategic planning for other events and other disease outbreaks through our emergency support now. It highlights, of course, the importance of supporting and protecting our laboratory staff throughout all of these events. Thank you so much, Gulnora. I'll pass over now to Diego, who will introduce us to the work in Colombia. Thank you very much. Diego.
Good morning, everyone. Thank you very much for this invitation. It is a great pleasure to represent the LHSS Colombia team and to share with you the progress that our country has made in strengthening laboratory diagnosis for COVID-19. Next slide, please. On this first slide, we can see the progress in the country's diagnostic capacity for COVID-19. The map on the left shows the scenario of March last year, with only one laboratory in the National Institute of Health. The map on the right shows what we currently have: 150 laboratories in 27 departments and the capital, Bogota. In green, the departments where PCR is processed. In orange, the departments that will be processed are the next department to process, and in red, where it's not possible to implement this due to its capacity. This reflects the commitment of the country, the integration of public and private laboratory networks, and the investment of resources of the country for this rapid growth. Next slide, please. Now we can observe the timeline of the expansion and opening of new laboratories in the country from March to the current date. It is presented by department and also shows the progress in the number of laboratories, as well as the capacity in processing PCR tests. For example, in the capital of Colombia, Bogota, we have 42 laboratories that process around 29,000 samples, and with Valle del Cauca, it increased to 61 laboratories that process 34,000 samples around. The last department to open a laboratory was Quindío, with which we completed 150 laboratories and around 63,000 samples daily. Next slide, please. This was the monthly increase in the processing of PCR samples daily in the country from March to date. This is very important because it shows how the country very quickly and in the first months of the pandemic adjusted manages to increase its diagnostic capacity for COVID-19. This slide, please. Next slide. This is how the procedure for taking and processing samples in our country is. First, the person with suspected with COVID or contact with a positive must call his insurer to schedule the taking of the sample at home by a health service provider specialized in this. In the cases of migrant people without insurance, only 2% of the total Colombian population, they contact the health secretariat to schedule the taking with a public hospital. Then, once the sample is taken, it is sent to the laboratories with which the insurers have contracts, and in the case of migrants or population without insurance, it is sent to the public health laboratory for processing in this or in the National Institute of Health at central level. In the Civigila platform, all the epidemiological information of the cases from which a sample was taken is entered for follow-up by the National Institute of Health and Secretariats. In the Sismuestras platform, all collaborating laboratories upload the report of all samples taken in the country. Next slide, please. LHSS Project has supported Colombia in hiring 34 rapid response teams in 34 departments. All the teams are made up of an epidemiologist, doctor, nurse, and nursing assistant that support the work of the health secretariats. These teams have been very important because they have strengthened the response capacity of the health secretariats to the pandemic, joining the work teams that the secretariats already have, which will never be enough due to the great demand for needs that the pandemic has generated. They are helping with the following action, among others: local implementation in departments and municipalities, a Colombian program called PRAS. PRAS means testing, tracking, and sustainable selective isolation. Training for health and community personnel who have been the direct beneficiaries of this work together with the personnel of the health secretariats, sampling in some specific cases where migrants and vulnerable communities are required. Follow up the trackers of suspicious and confirmed COVID cases in migrant population. Next slide, please. In this map, we can see the distribution around the country of the 34 rapid response teams. All of the teams officially finished their work on February 28th of the year, but we are working on a new strategy to continue supporting the department with the largest number of migrant population. Thank you very much for your attention.
Thank you very much, Diego. And I think, a few really important messages from your presentation is, highlighting the complex chain of events that occur for specimen collection, handling, and processing before samples even arrive at a diagnostic lab, and particularly those challenges for groups like migrants or other vulnerable populations. The other really key point is the importance of public and private collaboration for rapid scale-up in both emergency and more sustainable lab strengthening efforts. Thank you very much, Diego. I'll now turn over to my colleague Sampavan from the Louis Pasteur Institute to discuss our experience in Laos. Thank you.
Thank you, James. Good morning and good evening, everyone. First, I would like to thank USAID for giving me the opportunity to present at this webinar. Next slide, please. As the Chinese government alerted on the emergence of a new respiratory disease, to prepare for and respond to the arrival of COVID-19, as soon as January 2020, the Laos government implemented a COVID-19 task force as well as emergency operations centers. 4 public central laboratories located in Vientiane capital made with WHO to organize lab activities and information reporting. In February, the Ministry of Health recommended to wear face masks, hand hygiene, and social distancing. In March, manufacturing were suspended, school and office were closed, and restrictions on international travel implemented. People entering the country had to test 72 hours before arrival. They were then retested at arrival and then quarantined at designated center at all hotels. In April, a national lockdown was imposed with restriction on internal movement within the country. It was asked to the population to stay at home. In May, some restrictions were eased, such as the reopening of school and office, and reducing of movement between the provinces. Next slide, please. In terms of detection and control, when a positive case is identified, the patient is hospitalized until a negative test is obtained. The patient is discharged from the hospital after a true negative test. In the meantime, the contact testing is done to search for the close contact, and every close contact identified is tested, quarantined, and monitored. At the end of the year 2020, almost 92,000 cases were tested. Among them, 41 positive cases were identified. Most of them corresponding to the imported case through air travel. There was no death and no admission at ICU associated with these cases. Next slide, please. Regarding our activity at the Pasteur Institute, following the set up COVID-19 molecular diagnostic tool in January, we were then requested in February by the Ministry of Health as a frontline diagnostic laboratory with a surveillance network of 10 hospitals. We also train nurse, medical doctor of our partner hospitals on personal protective equipment, sample collection, and sample packaging. In April, we identify a positive case. In May, we participated in the external quality assessment set up by WHO. Since September, we also collected samples at Wat Sai International Airport in Vientiane capital. This allowed us to increase the number of tested samples during the last month. Next slide, please. In parallel of this screening activity, we will also perform the genetic sequencing of the viral strain identified to track the origin of the imported strains. For this purpose, a material transfer agreement is in signature with National Center Laboratory and Epidemiology. We also train lab technicians on all aspects of this activity. In parallel, we developed a research program dealing with the origin and transmission of SARS coronavirus 2 in the wild fauna in Laos PDR. Next slide, please. The COVID-19 pandemic has revealed some weaknesses at the central, provincial, and district levels. It revealed a lack of the qualified people, both in the term of number and of level of expertise, as well as a lack of the equipment and of the technological platform to perform a diagnosis. It also shows some difficulty in collaborating between hospitals and laboratories, and a lack of a rapid communication mechanism to share the information and learning. Next slide, please. Nevertheless, the COVID-19 pandemic has created the opportunities to increase the capacity and preparedness of the health system in its entirety. It allowed the implementation of the multi-source surveillance system to expand the capacities of the laboratories in central and province in terms of the human resources and technological platforms by preparing lab equipment, material, and supply to implement mobile PCR. In the meantime, lab technicians have had the opportunity to increase their capacity for the PCR technique and molecular biology in general. The pandemic also enabled to delineate a 2-year COVID-19 operational response and draft a 5-year strategy priority plan for the infectious diseases. Next slide, please. What is the impressive is that despite the resurgence of the new epidemic wave worldwide, the COVID-19 epidemic in Laos PDR is still to date under control, and the epidemic never took off the country. This might be explained by the rapid lockdown and development of an efficient surveillance system. This can also be due to the use of the population or to a natural cause immunity. But even if the COVID actually with a huge increase of the cases in neighboring countries such as in Thailand, Cambodia, or Myanmar. With the reopening of the international borders, quarantine and laboratory testing procedures will need to be adapted. Thank you for your attention.
Thank you so much, Sampavan. I think the experience in Laos has really underscored that despite similar challenges in equipment or human resources, the rapid and targeted planning and action for public health containment and early containment and public health measures can really be successful, and how diagnostics and contact tracing is a big part of sustaining that containment as borders reopen. I think you've also, touched on sequencing and other diagnostic research measures that will continually arm us as a global community with knowledge about this viral threat. Thank you to all our panelists. I'm now pleased to turn to the question and answer portion of our webinar. I'd like to encourage all of us in the audience and anyone who has something to say to submit your questions using the chat function on your screen. We know that many of you have experience with COVID and diagnostics throughout the first year of this epidemic, and we look forward to any questions from you. I'll start with a question to Gulnora, and this relates to some of the early discussions that were held regarding laboratory scale-up, diagnostic scale-up, and the impact that might have on services such as HIV and TB. What mitigation measures were put in place in Central Asia or Tajikistan to ensure the continuity of other diagnostic services? Thanks.
Thank you, James. I would like to start that, yes, from the very beginning, even when Tajikistan declared, placed itself as a COVID-free, WHO recommended to use TB and HIV testing capacities for COVID-19 diagnostic, mainly because PCR have much longer cycle comparing to GeneXpert. But in reality, in Tajikistan and in Central Asia, TB and HIV care is already overloaded, especially TB. So in order not to overload more TB and HIV care with COVID testing, government made a strategical decision to use TB and HIV capacity only for emergency cases, and main load of testing capacity for COVID-19 was put onto virological laboratories, which using PCR machines. I just wanted to mention here probably some very good experience we faced with both TB and HIV care that I mentioned previously during my presentation. When LHSS started working in pilot laboratory, there was no PCR machine at this laboratory, so it couldn't do any testing. We met with TB care and with HIV, and agreed that to move PCR machine from HIV center, because they had two, to pilot laboratory to start testing, and use TB trained staff to urgently start testing capacity in pilot district. So that's how we managed, and it was difficult at the beginning, but then it went very smoothly, and again, collaboration is a big thing that made success.
Thank you so much, Gulnora. Yes, certainly there was a lot of discussions of both relying on existing diagnostic capacities and knowledge without overwhelming them, so thank you for that. Diego, we have a question for you, and this relates to the importance of information sharing and surveillance as part of emergency response. And the question is, are the data in the Semuestras platform aggregated and made available to the public through the National Institute of Health? So that relates to diagnostic information and sharing both to the National Institute and the public itself. Over to you, Diego. You may be on mute, Diego.
James, thank you for this question. In Semuestras platform, the information is aggregated and really is not available for all population, only for the stakeholders and hospitals, Secretary of Health, and another institution that take any decision in this pandemic. And we have another platform that is Semuestras platform. We have Sirigila and Semuestras platform, two platforms. They are managed by the National Institute of Health and the laboratories that was approved for the testing to the PCR samples in our country. They have a key for consult all information of all samples in our country, and the health secretaries to have the key, and they are sending to the age people to these results of the sample.
Thank you so much, Diego. And if there's follow-up questions on that, we can certainly connect you to folks to discuss further. I'll pose the next question to Sampavan, and this relates to some of the geographic considerations that went into lab strengthening planning. And the question is, how did your regions or national plan strengthen laboratory capacity in remote or difficult to access areas? And was that a consideration in Laos? Over to you. Sampavan, can you hear us?
Yes. For the last year that we have lack of the serious outbreak because of in Laos we locked down very quickly, and also the density of the population not so very high, and also maybe the curse immunity, and in Laos mostly lack of the physical contact, and also in here we literally wear the mask to prevent the some pollution, and also every person come to Laos, they should to quarantine 14 days.
Thank you very much. And I think maybe we have a difficult connection with Sampavan. I'll pass this same question to Gulnora. How was regional or remote geography capacity considered in the Tajikistan response? Over.
Yes, it was challenging. First, in terms of capacity building. Second, in terms of presence of laboratory equipment. And last, transportation of specimens to the cities. So we and other partners tackled all those issues since the beginning. And for now, for example, we have 11 plus, I would say, laboratories all over the country that are doing testing. That probably is taking burden from the capital laboratories that was at the beginning. Over.
Great, thank you. Yeah, and I think both those comments highlight that there was a lot of discussion in the early days about how centralized the response should be, what burden that would place on central diagnostic capacity. So certainly in many of our countries, we've looked to establish at least regional hub laboratories or other interventions that place less burden on those central capacities. Diego, I have a question for you, and we might pose it to some other panelists, but a lot of what we've talked about today for diagnostic strengthening and planning and central level coordination really relates to health system strengthening. And so what do you think, or the health system strengthening efforts we've done over the past several months, what lasting effect will that have on the health system in Colombia? Over to you, Diego.
Great. About this question, I think that Colombia is making many efforts for strengthening the capacity of the laboratories in all areas in our country. As we can see at the map in my presentation, we have laboratories now for processing PCR in around all country. Only 3 regions don't have, because this is the areas more rural, more dispersed, and more so far to the central of the country. But really, this is very important for the capacity that we have strengthening in the laboratories and the integration between public, laboratories and private laboratories in our country. That really this is a challenge for us, but it's a very thing important for show in this experience with COVID-19.
Thank you, Diego. And there was actually a follow-up question I'll ask now regarding that private sector involvement. And can you talk a bit more about how the private sector was involved in that collaboration? For instance, were agreements already in place with such labs, and what other type of challenges or logistic issues were faced in that private engagement? Over to you, Diego.
The integration between network, public and private laboratories in our country really is not new for us. In Colombia, all laboratories have reports about CIVIGILA platform, all the information in different diseases historically. And we have the experience with another diseases and another outbreaks. I can't remember outbreak by measles any years ago. And really, the National Institute of Health has been making very good work, integrated these networks. And really, for these 150 laboratories currently, more laboratories are with the private laboratories with investment of resources, private resources, and with the help of the government. But the more resources really in our country are in the private, acquiring machines for processing PCR. That this is not only for the processing COVID-19, but another viruses is possible processing with this. Now Colombia have any highest capacity for processing PCR samples here.
Great, thank you so much, Diego. Sampavan, I'd like to ask you a question. In terms of the rapid laboratory scale-up that occurred in Laos, was there any issues of infection among laboratory personnel or in the laboratories? How was biosafety and security addressed in your response? Over to you, Sampavan.
No, because in here we even for example in Pasteur Institute we will do the test or the extraction in the BSL-3, but in the National Central Laboratory and Epidemiology they use the BSL-2, but everyone have to use the good PPE to do the test to protect it, and also for the person to collect the sample, they have to train how to wear the PPE, and also is to use the coverall to collect the sample.
Great, thank you so much, Sampavan. And Gulnora, in Central Asia and Tajikistan, was there a challenge with COVID-19 infection within any of the laboratories? And connected to that, what sort of incentives were offered to healthcare workers for those long working hours and risks? Over to you.
Thank you, James. We had issues with infection control in laboratories. Especially as I mentioned, only one national laboratory was meeting international standards in terms of biosafety, security, and infection control. So we actually had to train staff on infection control to strengthen their knowledge. Did some procurement in order to laboratory to meet international standards in terms of infection control. and some of laboratories unfortunately were closed nationwide, not our pilot but others because of contingency. And in terms of incentives, that's a pity issue. I would say officially, yes, there was law, it was an order that all healthcare workers, including laboratory specialists, have to get some extra payment for extra work and 24/7 work. But unfortunately, I have to say that in reality, it was not in place.
Mm-hmm. Mm-hmm. Thank you very much, Gulnora. Thank you. And Sampavan, in terms of the protections and so on you described in Laos, were incentives offered to healthcare workers for those extra working hours and risks? Over to you, Sampavan.
Could you repeat again?
In terms of the laboratory personnel that were engaged in the Laos response, were they offered incentives, either financial incentives or other rewards for the long working hours and the exposure risk they faced? Over. Perhaps we're having connection issues.
Yeah, it's depending on it's depending on the each institute. For some example, for the National Center Laboratory and Epidemiology, the government will support them. But for the pastor, we will use our own budget or own financial to support our staff.
Thank you.
Can I add anything about this, James?
Diego, yes, please.
In Colombia, the national government offers economic incentive for all personnel of health in clinics and in surveillance and in laboratories. That really is a incentive that promote that the personnel health are more happy and more emotionally quickly about this, and really is a great for us.
Great, thank you. And following up with you, Diego, there's been a couple questions here about specimen collection and transport. So the first question is that, many communities are facing challenges in scaling up specimen transport to labs in a safe, timely, and high-quality manner. Could you share any experience on linking specimen referral or specimen collection to laboratory processing? Over.
In the aerial rurals or so far areas in our country, the insurers and the hospital, they take the samples and they have contracts with transportation for the samples to the hospitals, to the laboratories, regional laboratories or central laboratory of the National Institute of Health. But historically too, the laboratories or the hospital will take any sample, not only with COVID-19, they had sent to the samples to the central level for the processing. And really, this is not new for us, but we had any good experience with this and don't have problems with the cold chain with these samples.
Thank you. And maybe Gulnora, following up, same question to you in terms of the collection, handling, and transport of specimens to central or regional level. Have there been any challenges or lessons you'd like to share?
Yes, indeed. At the very beginning, there was an issue with transportation. That is why we had a lot of, how I would say, not spoiled tests, I would say, that needed to be repeated, because the whole transportation chain, including sometimes the taking the test itself, was a challenge. So we had actually to train laboratory specialists, including PHC facilities, healthcare workers, because in our country, healthcare workers from PHC were the ones who really went into the households sometimes to do the swab tests. So we had to train them as well. Then the other decision to tackle this issue with transportation and specimen collection, not specimen collection, but with transportation, was expanding laboratory capacity into the other districts and regions in Tajikistan. So it won't be an issue of 6 or 8 hours transportation to the national lab. Over from
Thank you. Thank you very much. And I think, from a central level in all the countries, our concept of lab strengthening really did begin with specimen collection and thinking technically through all of those pre-analytic interventions that needed to occur to ensure specimens were viable even before analytic interventions were done at the lab. So I think each country has had their own experiences in that issue. Sampawan, a question to you in terms of moving forward with diagnostic procedures and screening. Are there any plans to add or overlay serology testing within the laboratory network to evaluate seroprevalence or vaccine efficacy in the future? Any plans to add serology testing to your program? Over.
Yes. Now we are in our institute. We also do the research for the seroprevalence in Laos PDR, and now we already collect this sample, and we will test soon, and then we will give all the information to the government, and then for them to think about the vaccination in the future. That's all for my answer.
Thank you very much. And maybe Gulnora, same question to you. Do we know if there's any plans to add blood serology to future plans?
Actually, it is already in place. Our pilot laboratory started to do IgG/IgM in November. With the support from other donors. As I mentioned, we really want to drag attention from other donors to make their input into laboratory service. So it's actually within the country already laboratories who do the COVID tests, PCR COVID tests. They also do ELISA as well.
Thank you very much. There's another question here regarding procurements, and it's: did you experience any bottlenecks on the supply of lab materials for real-time PCR, and if so, what did you do? I can answer that briefly from the central level, and then Gulnor, maybe you can answer in Tajikistan. But LHSS, certainly across many of our countries, has been closely involved with USAID in procuring both rapid PCR consumables, but also heavy PCR machinery for national responses. We've worked closely with our procurement team to do that. Bottlenecks have included border customs clearance issues, the changing nature of border closing and reopening, long lead times, lack of supply, and a very complex global market for all of these materials. But I'm happy to report that working closely with USAID and several global suppliers, we've been able to address some of these needs. Gulnora, maybe can you speak a little bit more directly on that experience in Tajikistan with the procurement of material?
Sure. I will probably start with success that, again, to repeat that LHSS was the first international partner to bring PCR machine. So the others were far too late, and we placed our in September, which was very significant support to the government. And yes, James, we're right, we faced quite a number of challenges. Starting from, because Tajikistan do have only one road coming in and one road coming out. So it was because of COVID, all borders were closed. No one really knew how the cargo will pass all 6 or 7 countries to come to Tajikistan, but it happened. From the consumables point of view, in April, May, there were challenges, and again, it was because it was emergency response. There was a PCR machine, there were tests, but some consumables didn't match PCR machines. Some tubes were not matching tests. So, and as a result of collaboration and really negotiations between implementing partners, from June onwards, everything became clear and straightforward. But at the beginning, yes, we did face a number of challenges. Over from my side.
Thank you, Gulnara. And certainly the real discussion point for all procurements was that coordination piece with CDC and WHO and other USG partners, all looking to procure what was necessary in a short period of time. So Tajikistan was definitely an example of success in that area. Diego, a question for you. In Colombia, given the success of the rapid response teams, is the MOH building rapid response into pandemic preparedness planning for the future? How has this experience helped shape future planning? Thank you.
Thank you, James, for this question. The Ministry of Health and the Health Secretariat have been working on their transition plan for when the rapid response teams are finished. In fact, one of our deliverables is a roadmap for the deployment of these teams in future emergencies. Additionally, the capacities of health and community personnel have been strengthening, and all personnel remains in the department, and it is the key to give sustainability to our actions. It's the personal health, community population, and all this population really thinking about the sustainability of the project actions.
Thank you very much, Diego. My last question before we'll wrap up is to you, Sampawan. In terms of the sequencing, as we look forward to the future, in terms of the genetic sequencing work Pasteur Institute is engaged in, how is that positioning the Laos Ministry of Health and other partners for longer-term resilience? Could you talk a bit more about our efforts to understand this virus now and in the future? Thank you.
Yes. Now, the Pasteur, we are preparing the material transfer agreement with the National Central Laboratory and Epidemiology to get the sample to do the sequence. And now in our institute, we are trying to sequence the virus very early. And then all the information we will report to WHO and also our MOH. And we will look at the virus from the imported case. Are there the mutation or not? And we try to find the origin of the virus that are in Laos PDR. That's all.
Thank you so much. And thank you to all our panelists today for your presentations and to our audience for your engaging questions. We certainly weren't able to get to all of them, but I think that today has been such a great summary of some of the key issues we've all faced over the last year together, from the early response to, and trying to understand the science of this virus, to the challenges we've described with specimen collection, handling, and transport, the decisions of where to place analysis and diagnostic processing, equipment and consumable challenges to do so, and then sharing of and reporting of that information for ongoing planning and information sharing was critical. I think, again, to summarize that at LHSS and in our work with USAID, we have tried as best we can to use this emergency as an opportunity to build health systems for the future, and diagnostic capacities and strengthening laboratory workers has been a central part of that. I'd like to thank everyone who joined in and all of you who submitted your questions. We'll be sending out a recording of today's webinar next week, so be sure to watch your email boxes for that. Again, thank you to all. Stay safe and have a great rest of your day. Thank you very much.